Today's class, we are going to discuss on acute gingival infections. What do you mean by acute gingival infection? So acute gingival infection is mainly three types. That is, one is necrotizing ulcerative gingivitis, one is necrotizing ulcerative gingivostomatitis, is primary herpetic gingivostomatitis, or pericoronitis. So these three are the main acute gingival infections. So in that, important one is necrotizing ulcerative gingivitis, but commonly seen is pericoronitis. Pericoronitis means when you have swelling at the wisdom tooth, non-erupted eighth, mainly the lower molars, that is 3/8 or 4/8, and sometimes even 1/8 or 2/8. Pericoronitis, patient will be having difficulty in opening the mouth, swelling and things like that. But necrotizing ulcerative periodontitis, the patient will be having inflammation or pseudomembranous sloughing of the gingiva. So what is necrotizing ulcerative gingivitis means? It is a microbial disease of the gingiva in context of the impaired host response. Because the host response is impaired, the chances of necrotizing ulcerative gingivitis is more. It is characterized by the death and sloughing of the gingival tissue and presence with characteristic signs and symptoms. It has a typical signs and symptoms than other diseases. So seeing that clinically, you will be able to identify that it's mainly or you can diagnose it with the particular finding that or particular sign and symptoms of what is presenting by the patient. You can diagnose it as necrotizing ulcerative gingivitis. What are the other names for necrotizing ulcerative gingivitis? Other names are ulceromembranous gingivitis, acute necrotizing ulcerative gingivitis, otherwise shortly called as ANUG. Earlier it was called as ANUG, ANUG. Now it is called as NUG only. And Vincent's gingivitis or Vincent's gingivostomatitis or Vincent's stomatitis or necrotizing gingivostomatitis and trench mouth. And what is the prevalence or epidemiology of this disease? It has an endemic pattern and it is seen mainly in increasing in the developing countries like India, and 0.02 to 0.08% or lesser in interlaced countries, and 54 to 58% in Indian population. And ANAC is more in HIV positive patients. And the main one attractive or one contradictory or like interesting feature is that ANAC has different presentation in HIV positive patients and different presentation in HIV negative patients. What are the clinical features of necrotizing ulcerative gingivitis? The clinical features mainly the classification. It is classified into acute, subacute. That is mainly in the gingival tissues, and when it invades the periodontal tissues, it is called as necrotizing ulcerative periodontitis. When bone loss occurs in acute and subacute, only gingival tissues are affected. And the history of NUG is it's of sudden onset. It's one of the debilitating diseases that patient will be having difficulty in eating or swallowing and things like that. It's a debilitating diseases, and it mainly seen in patients who have change in living habits, poor socioeconomic status or poor nutrition, patient having stress, or patient using severe tobacco usage like pan, hands, and things like that, even smokers. But mainly it's a poor nutrition, so it is mainly associated with poor socioeconomic status. And these are the typical signs you can see of NEC. No other gingival condition you can see this. The main characteristic is a punched out crater-like depression at the crest of the interdental papilla. The interdental papilla, crater-like depression, you can see the interdental papilla. And another typical feature of NEC is gray pseudomembranous slough with linear erythema. that the grayish or the sloughing of the tissues will be there with linear erythema. These two are the characteristic feature of an. Seeing that clinically, you can diagnose it easily as necrotizing ulcerative gingivitis. And spontaneous gingival hemorrhage or pronounced bleeding on slightest stimulation. Just you touch with your finger or any with a toothbrush, there will be spontaneous hemorrhage, but on the slightest provocation or stimulation. Even it can occur in disease-free mouth or be superimposed on chronic gingivitis or periodontitis. It can be presented. Necrotizing ulcerative gingivitis can be presented without. In a disease-free mouth means there is no gingivitis, no periodontitis, nothing. It can be seen in those type of patients, and you not also it is superimposed on chronic gingivitis or periodontitis. And other thing is that usually the patients who have an they will be presented with the poor oral hygiene because they will be coming to you after a long time because they will be doing their own medications and they will be dealing with themselves. Then it's not subsiding. Then they'll come to the dentist. So usually you'll be seeing they will be having poor oral hygiene with difficulty in brushing or maintaining their oral hygiene. The oral symptoms, we have seen the signs. Now the symptoms are the patient will be having fetid odor, that will be bad breath will be there. Extremely painful to touch because of the sloughing of the tissues. The gingiva will be extremely painful to touch. And patient will be always complaining of constant or radiating or gnawing pain. Patient will they will be feeling very irritated and metallic foul taste will be seen. And they will be usually complaining of excessive amount of pasty saliva. Pasty saliva will be seen. The excessive amount because the saliva they'll be telling us that the saliva will be of a pasty type saliva, and they'll be like if they though they spit it out also the saliva will be like that. And the extraoral signs and symptoms, the patient may or may not have systemic complications. That's not a must because they might have or they may not have systemic complications, and there will be localized lymphadenopathy because the lymph nodes will be palpable. And usually patient will be presenting with high fever, increased pulse rate, leukocytosis, loss of appetite, and general malaise or lassitude. So fever, pulse rate will be increased, leukocyte increase, leukocyte content, and patient will be having loss of appetite. And what are the clinical course of an? And if it is treated in the beginning, okay, fine. If it's not treated, it has the following stages. And Pinberg classified NUG into following stages. The 4 stages are: one is only the tip of the interdental papilla is affected. That's the first stage. And if not treated or not diagnosed, then the second stage, the lesion extends to the marginal gingiva and causes punch out crater-like depression on the interdental papilla. That is a typical oral sign which is presented by ANET. And in stage 3, it is the attached gingiva is affected. So you can see that only the interdental papilla, then it is going down, marginal gingiva, then it is again going down, it is affecting the attached gingiva. Then the 4th stage, the bone will be exposed. Bone will be exposed means there will be norma or canker moris or whatever it is you call it, that it progress to necrotizing ulcerative periodontitis. First 3 stages, only the soft tissue is affected, and the 4th stage, hard tissue is affected. Hard tissue affected, it changes to NUG. NUG changes to NUP, that is necrotizing ulcerative periodontitis. And Horning and Cohen has classified it as in 7 stages. So you can note down and you can very well write it for the exam because stage 1 there is necrosis of the tip of the interdental papilla. In 93% of the cases, the presentation will be like that. Stage 2, there will be necrosis of the entire papilla, that is about 19%. And stage 3, necrosis till the gingival margin, that is up to 21% of cases are seen. And stage 4 is necrosis till the attached gingiva, that's very minimal, is only 1%. And then it progresses to other that's mainly affecting the bone. Stage 5 is necrosis till labial or buccal mucosa. So after that, gingivitis is going to the buccal vestibule. That's up to 6%. And stage 6 is necrosis till alveolar bone, that is 1%. And necrosis till skin of cheek, that is 0%. That is stage 7. You can see in the photograph, you can see that the gingival scalloping is lost. You can see that there is sloughing of the tissue mainly in the interdental papilla. The contour is lost. And in this photo, it's from the current textbook. In this photo, you can clearly see that between 1 and 2 there is sloughing of the internal papilla with the gray pseudomembranous stuff. Sloughing is that cream color thing in the marginal gingiva, and the other areas you can see that. And this stage you can see the bone exposure between canine and the premolar, that it's changing to necrotizing ulcerative gingivitis, changing to necrotizing ulcerative periodontitis. The same case palatal side, you see that there is bone affected. The lower anterior cases, the sloughing later stages produced, it attached affected the attached gingiva of the lower anteriors, as we told earlier. And next is a cancromoris or normal. It affects the bone. There is necrosis or gangrene of the underlying periodontium or underlying bone. You can see the upper and lower areas. So what is the histopathology of a neck? Histopathology, non-specific acute necrotizing inflammation can be seen. Surface epithelium is destroyed and replaced by fibrin necrotic cells, polymorphonuclear neutrophils, and various microorganisms. Surface epithelium is destroyed. That is the normal gingival epithelium is destroyed, replaced by fibrin, which means clot, necrotic cells, dead cells, polymorphonuclear, because neutrophils, you know, that's the primary line, first line of defense. Various microorganisms, because the infection of the tissues, the dead tissues are seen. So various microorganisms will be there. Underlying connective tissue is hyperemic with numerous engorged capillaries and PMS. The capillaries will be engorged, which it will be dilated, and underlying connective tissue will be hyperemic, means it will be severe hemorrhage and hyperemic. It will be like that. And plasma cells and monocytes are found in the deeper tissues. Deeper the histopathological findings you go, there will be plasma cells and monocytes. In the bacterial flora, predominantly spirochetes and fusiform bacteria are seen, and spirochetal organism forms a light staining, conspicuous interlacing network will be seen. Electron microscopy classifies spirochetes into small spirochetes up to 7 to 9%, medium spirochetes 43.9 to 90%, and large spirochetes 0 to 20%. And the interesting part is that the bacteriology is different in HIV positive and HIV negative individuals for NET. In HIV positive individual, Treponema denticola, Selenomonas, Fusobacterium, melanogenicus, and Periodontal intermedia are seen mainly in HIV positive individuals. And the bacteriology for HIV negative individuals, mainly Borrelia winstonii, gram positive cocci, beta hemolytic streptococci, and Candida albicans are seen in HIV negative individuals. It's an interesting finding for NUG, because the bacteriology is different, entirely different bacteria in HIV positive individual and entirely different bacteria in HIV negative individual. So, HIV positive, it will be Treponema, Selenomonas, Fusobacterium, melanogenicus, and Periodontal intermedia. And for HIV negative, it will be Borrelia winstonii, gram positive cocci, beta hemolytic streptococci, and Candida albicans. Candida, you know, that's a fungal. And relation to bacteria, relation of bacteria to characteristic lesion. So Listgarten described it as 4 zones. One is the zone 1 is the bacterial zone, zone 2 is the neutrophil zone, and zone 3 is the necrotic zone, and zone 4 is the zone of spirochetal infiltration. Listgarten divided it into 4 zones. And how you diagnose? Diagnose is easy and treatment is difficult. because it has a typical clinical sign that's the pseudomembranous slough and crateral depression on the interdental papilla. So clinical findings, you can see the interproximal necrosis and ulceration. The gingiva will be painful and there will be bleeding, spontaneous bleeding on slight stimulation. Microscopic examination may not be sufficiently specific to be diagnostic because the clinical findings you should come to a diagnosis. And it has lots of same characteristics of other thing like the differential diagnosis. It's a bit confusing, but only thing and it can be diagnosed with the we told earlier sloughing of the tissues and crateral depression of the interdental papilla. Different diagnosis: streptococcal or gonococcal gingivostomatitis, desquamatic gingivitis, aphthostomatitis, tuberculosis, candidiasis, agranulocytosis, Vincent's angina, necrotizing ulcerative gingivitis in leukemia, and stomatitis veninata. So differentiation between necrotizing ulcerative gingivitis and primary herpetic gingivostomatitis. Necrotizing ulcerative gingivitis. Etiology is interaction between the host and the bacteria, most probably fusible spirochetes. And herpetic, it will be of specific viral etiology. Now, this necrotizing condition, herpetic is a diffuse erythema and vesicular eruption. Punched out gingival margin, pseudomembrane that peels off leaving raw areas. Margin gingiva is affected. Other oral tissues will be rarely affected. Vesicles rupture and leave slightly depressed oval or spherical ulcer. And diffuse involvement of the gingiva may include even buccal mucosa and lips. Uncommon in children, but primary herpetic gingivitis occurs more frequently in children. There is of no definite duration, but like all viral infection, it lasts up to 7 to 10 days. And no demonstrated immunity, but in primary herpetic, an acute episode results in some degree of immunity. And contagion not demonstrated, but primary gingivitis, it is usually contagious, like can be spread from one person to other person. Differentiation between NUC, desquamatic gingivitis, and chronic periodontal disease. You can note that bacterial smears of fusible spirochetal complex in desquamatic numerous epithelial cells and few bacterial forms. And in chronic periodontitis, bacterial smears are variable because of the bacterial content difference. Usually marginal gingiva is affected. Diffuse involvement of marginal and attached gingiva and other areas of our mucosa. And even in chronic periodontal disease, marginal gingiva is affected. That is of acute history, and both other things have the chronic history or long-term history, and usually painful. Desquamative and periodontal disease is not painful. Pseudomembranous sloughing is seen. Patchy desquamative gingival epithelium, no desquamation, but pural material may appear from periodontal pocket. Papillary and marginal necrotic lesions. Papilla do not undergo necrosis in both other two conditions. Affects adults of both genders. Affects adults, mostly women, desquamative, and generally in adults, occasionally children. Characteristic fetid order for NUC, none in desquamative gingivitis, some order, but it's not a striking feature. Differentiation among NUC, diphtheria, and secondary stage of syphilis. For differential diagnosis, but etiology interaction between host and bacteria, we told earlier, marginal gingiva membrane remove easily, the slough can be removed easily, marginal gingiva is affected. Serological finding normal, immunity not confirmed, not contagious. Antibiotic therapy relieves only the symptoms. Diphtheria and all rarely affects marginal gingiva, less painful, but mainly because of corynebacterial diphtheria, and syphilis it's because of Treponema pallida. So the entirely bacterial that is different. In the, both other thing, both are not painful, and throat versus tonsils are affected. Any part of the mouth affected. Immunity conferred by attack, contagious. Antibiotic treatment has only little effect, and in syphilis, antibiotic treatment mainly doxycycline has excellent result. Coming back to etiology, bacteria plays so many 5 factors here: role of bacteria, role of host response, local predisposing factors, systemic predisposing factors, and psychosomatic factors. So etiology, combination of fusiform and spirochetal organisms, that's main role of bacteria. Role of host response, because the immunity is reduced, superinfection and can happen. Local predisposing factor, pre-existing gingivitis or periodontitis, smoking or injury to the gingiva. Systemic predisposing factors like mainly nutritional deficiency, we told about socioeconomic status, poor diet or poor vitamin intake, patients having debilitating disease like HIV. And another main factor is psychosomatic factors, mainly stress, communicability of the disease, and treatment is of yeah. One is alleviation of the acute inflammation plus treatment of chronic disease, either underlying the acute involvement or elsewhere in the oral cavity. Alleviation of generalized toxic symptoms such as fever and malaise, and correction of systemic conditions that contribute to the initiation of these 3 factors has to be considered by doing treatment. One is alleviation of the acute inflammation, plus treatment of chronic disease and underlying any involvement in the oral cavity. Alleviation of generalized toxic fever and malaise has to be treated. Correction of systemic conditions that contribute to the progression of the gingival changes. So the sequence of the treatment. But the first visit, proper history and thorough examination is done. Pseudomembrane is left, is removed under topical anesthesia with cotton pellets. You do it very slowly. Areas cleansed with warm water. Superficial scaling can be done, only ultrasonic scaling very superficially. Rinses with hydrogen peroxide or chloroxylene is done. And if required, like if the condition is painful or sloughing is there, antibiotics and analgesics are prescribed, and patient is instructed to avoid smoking and avoid alcohol, avoid physical exertion. Patient will strain too much and avoid brushing over the area so that the issue will heal by itself. Second visit, 1 to 2 days of the first visit, again do a gentle scaling, same instruction as the first visit. Third visit, 5 days after second visit, again you do scaling and root planing, and subsequent visits you do rechecking and scaling of the areas. And additional treatment consideration, contouring of the gingiva, like if the gingiva is in a different shape or like the sloughing gingiva, the contour of the gingiva will be lost. You can do contouring by gingivoplasty. Systemic antibiotics and topical antimicrobials. If the patient is having sloughing and pain and things like that, you can give systemic antimicrobials or topical antimicrobials. Supportive systemic treatment, like supportive like any other treatment, and nutritional supplements has to be given. If the patient is very weak, you should always give nutritional supplements. And in persistent or recurrent cases, like you should do the reassessment of different diagnosis because you want to check whether your diagnosis has gone wrong. So reassessment of your differential diagnosis. Underlying systemic diseases causing immunosuppression should be identified because what is causing the immunosuppression should be identified. Any other systemic conditions causing it, it should be treated. And if your local therapy, sometimes you do scaling and root planing, and if the patient is having bleeding, you will be doing it in a very slow or very difficult manner. So inadequate local therapy, you have not removed calculus or block. So again, recurrence chances are there, and inadequate complaints by the patient. Patient is not willing for the treatment. Second is primary herpetic gingivostomatitis. Mainly, you know that it's a viral infection. So it's caused by herpes simplex virus 1, and it is commonly seen in infants and children more than 6 years of age. And it can occur in older individuals also, but mainly in children it is seen. It's symptomatic in many persons. There is no sex prediction. It can cause in females or males. Persists in the neuronal ganglion after primary infection. And secondary manifestation occurs as a result of various stimuli like sunlight, trauma, fever, or stress. Clinical features: the oral stains, diffuse erythematous, shiny involvement of the gingiva and adjacent oral mucosa, accompanied with varying degrees of edema and gingival bleeding. There will be discrete spherical gray vesicles on the gingiva, labial and buccal mucosa, soft palate, pharynx, sublingual mucosa, and tongue are seen in the initial stage. Then they rupture and form painful small ulcers with red elevated halo-like margin and a depressed yellowish or grayish white central area. And the course of the disease is limited, like all other viral infections, 7 to 10 days. And it heals normally without any scar formation. You can see that it affects the lip, or in the first diagram, you can see that it affects the lip, and there is a slight bulge or swelling of the lip. In the second diagram, you can see that herpetic area, that in the viral area, that it affected mainly the lips and even the palate. You can see the vesicles there. Vesicles on the tongue and even the gingival margin it is in. The oral symptoms mainly generalized soreness of the mouth. The pain is present and lesions are sensitive to touch, thermal changes, and even food. So the pain is present when the patient is having food, or any patient is having any thermal, like cold or hot foods, and even sensitive to touch. External signs are cervical adenitis or fever up to 105 to 105 degree Fahrenheit. And history mainly is contagious, history of exposure to a patient, history of febrile disease like pneumonia, meningitis, influenza, and typhoid. And it also occurs in early stages of infectious mononucleus. Very rare, but it occurs in the early stages of infectious mononucleus. Histopathology, epithelial cells are targeted. Cell shows ballooning degeneration consisting of acantholysis, nuclear clearing, and nuclear enlargement. The presence of Shank cells are seen, and infected cells fuse and form multinucleated cells and intercellular edema. This in turn leads to the formation of intraepithelial vesicles that ruptures and develop a secondary inflammatory response within a fibropurulent exudate. There will be discrete ulcerations results from rupture of vesicles having a central area of inflammation with a purulent exudate surrounded by a zone rich in blood vessels. There will be discrete ulcerations results from the rupture of vesicles having a central area of inflammation with a purulent exudation will be there surrounded by a zone rich in blood vessels. Diagnosis with a history and clinical findings and confirmatory tests. You can include viral culture or immunological test because it has a specific etiology, unlike NUG, because of the viral infection. And differential diagnosis mainly erythema multiforme, Stevens-Johnson syndrome, bullous lichen planus, dystomatic gingivitis, or recurrent aphthostomatitis. And communicability, it is highly contagious. In NUG communicability, it is not contagious. In primary herpetic stomatitis, gingivostomatitis is highly contagious. Treatment usually self-limiting disease, particularly the nerve path it will be seen, and rarely specific. And treatment consists of palliative measures to make the patient comfortable until the disease runs its course of 7 to 10 days. Scaling is done to reduce inflammation, but mainly not done in the first 3 to 5 days. Lidocaine or topical anesthetic hydrochloride mouthwashes are given before food, so patient will be having little comfort because otherwise there will be burning sensation, pain of becomes. NSAIDs can be given if the patient complains of severe pain. Antibiotics sometimes recommended because viral there is not much use, but if there is severe sloughing and things like that, antibiotics can be advise the patient to take lots of fluids. That is a must. And herpetic whitlow, that's the patch like thing seen on the fingers because the children mainly they put their fingers in their mouth, and because of the infection it is contagious, so it comes to the like seen on the fingers of the kids mainly. And this is a another thing, it's the main thing like the patient comes to your clinic, pericoronitis refers to the inflammation of the gingiva in relation to the crown of an incompletely erupted tooth. Because partially erupted third molar, mainly the 3/8 or 4/8, and because gingival tissue will be there. It occurs mostly in the mandibular third molar region. Maybe acute, subacute, or chronic. Acute, they will be having severe pain. Subacute, okay, fine, and chronic, usually won't have pain. And the clinical features, mainly seen in the partially erupted or impacted third molars, is the most common site. There is accumulation of food and bacterial growth between the space of tooth and overlying gingiva. Inflammatory fluid and cellular exudate increase the bulk of the flap because exudation, the flap will be enlarged, which interferes with when the patient closes the mouth. Because of the inflammation, it will be difficult. Patient will have pain and aggravate the inflammatory process. And there will be marked red, swollen, separating lesion, which is extremely tender with radiating pain. There is a foul taste, and even in severe infection, there will be trismus. Swelling and lymphadenopathy are seen with systemic complication because there is swelling and associated inflammation, infection. So there will be severe lymphadenopathy will be there. You can see this in this diagram. You can see that the third molar is erupting and the flap will be there. So the loose flap causes food accumulation and things like that, and leads to inflammation of the surrounding tissues. And once the inflammation of it swollen, it increase in size. So when the patient chews, the upper tooth will come in contact with it. So the patient will having severe pain. You can see the other diagram. Photo, sorry, they are not diagrams. Photo. You can see that in the lower right side, you can see that partially erupted. So there is swelling. So usually when the patient goes a mouth, it affects that area. And complication is that if untreated, it causes pericoronal abscess or peritonsillar, and other one is peritonsillar abscess, cellulitis, and Ludwig's angina. This complication increases. Pericoronal abscess, okay, fine, can be treated. Peritonsillar abscess, it is difficult to diagnose and treat. And cellulitis, you know, the inflammation of the cellular area. Ludwig's angina, you know that the inflammation crosses the midline. The patient may have severe swelling here, and the tongue will be lifted in the mouth. It's a serious condition. And the treatment, all pericoronal flaps can be removed as a preventive measure. Because of the flap only, mainly the infection started. So you can remove the flap, and if there is space, the tooth will erupt by itself. In acute condition, patient complains of severe condition, you can flush the area with warm water, swabbing with antiseptic solution in the affected area, and antibiotics and NSAIDs are prescribed for reducing the infection and inflammation. And drainage is done if abscess is present. And in chronic condition, decide to whether to extract the tooth or to save it by doing operocolectomy or pericoronoplasty. And pericoronal flap is removed either by blade or electrosurgery, or when laser surgery, the flap is removed in chronic condition. You can see that the tissue is being removed. Once the tissue is removed, you can leave it to heal by itself. So you can see that first diagram, the tissue is removed. Second diagram, the gingiva, the incision is done. And third diagram, you can see that the gingiva is ready, come to the normal position, and the tooth is erupted. So there is no chance of inflammation there. So you can easily see that. So to wind up, what are the main three acute gingival infection? Main three acute gingival infection are necrotizing ulcerative periodontitis, primary herpetic gingivostomatitis, and pericoronitis. Necrotizing ulcerative gingivitis is seen with the typical oral sign, that is a great pseudomembranous sloughing of the tissues, and there will be crater-like depression of the interdental papilla. Primary herpetic gingivostomatitis mainly affected children more than 6 years of age, and it runs in course of 7 to 10 days, like oral viral infection. Then it has a etiology, wide etiology. It can be of stress, it could be of poor nutrition, it could be of bacterial origin. And another thing is that the bacterial flora of neck is seen in different in HIV positive individual and HIV negative individual. And the treatment is different. The treatment Neck is differently, multiple visits are there. So in the next class, we having further discussion on neck. Thank you.